So welcome everyone. I'm Professor Jonathan Barrett from the University of Leicester in the UK. And over the next 20 minutes or so, I'm going to talk you through the feedback I've had from patients from both in the US and across Europe and in my own unit about the challenges of living with IgA nephropathy and how important it is for there to be good communication and a good relationship between the nephrologist and the nephrology service and the patient to ensure patients receive optimal treatment and the best outcomes. Here are my disclosures. When I talk to patients, the overwhelming message I get is that before their diagnosis, they were leading completely normal lives. They felt well, by and large. They did not know there was an illness, they had an illness. They were really just enjoying life at a time, often in their 20s and 30s, where they were developing their careers, thinking about starting families, developing relationships. And the diagnosis of IgA nephropathy came completely out of the blue. And they may well have had a urine dipstick test for a health insurance policy or changing work. They may have had a blood pressure check, perhaps at a gym, or they may have had a blood test for some completely other reason. And this then has triggered eventually a referral to a nephrologist and a diagnosis. But what I hear time and time again is that often in hindsight, patients have had multiple tests that haven't been picked up on, or they've seen doctors who have ignored abnormal urine dipsticks or thought the blood pressure was not significantly elevated or the blood test was just marginally abnormal, but nothing needed to be done at the time. And what we see time and time again is that there's been a delay in referral to nephrology services. And what this means when we see our patients for the first time is many times our patients are frustrated because we give them a diagnosis of IgA nephropathy eventually, but what happens is they then look back at what's been happening to them and realize actually there were lots of missed opportunities for a diagnosis to be made. And I think if you talk to your patients, you'll probably hear this very often as well, that they've been bounced around between perhaps the emergency room in the United States or their GP in the UK. They might have even seen other hospital consultants, and no one's put two and two together and thought that there may be an underlying glomerular disease. And of course, when patients are referred to nephrology, there's a whole array of different approaches that are taken by nephrologists. And we need to accept that patients pick up on this. So if we think about the traditional teaching about IgA nephropathy that's in the textbooks that we'll have been taught when we were training, that are in relatively recent review articles, we know what the exciting kind of supercar glomerular diseases are, don't we? We know lupus nephritis, ANCA vasculitis, TMA. These are diseases we really need to know about. We need to diagnose early. We need to treat early. There's a sense of urgency about these diseases. And because of that sense of urgency, we take notice of new developments. We write up about it because this is something we don't want to miss. When we think about IgA nephropathy, we perhaps have a very different view if we go back to how it has been taught to us in the past. It's a slow disease. It's not a disease that's particularly exciting. It certainly isn't the supercar of nephrology, let's face it. And actually, that leads to a sense of complacency within the nephrology community. We've not had any treatments to treat the disease other than giving RAS inhibitors and general blood pressure control and lifestyle advice. So why should we go about making a diagnosis in someone we clinically suspect of having IgA nephropathy? And of course, what's the general view has been that the risk of kidney failure is very low in this disease, and actually it takes a very long time to happen. And so again, why should we really worry about this slowly progressive and insidious disease rather than one of those acute diseases where we need to be on our game from time zero to be able to get on top of it? And of course, the other challenge we have, because IgA nephropathy is an uncommon uh, type of kidney disease is many general nephrologists don't have that many patients with IgA nephropathy. And because of this general feeling that IgA nephropathy is not a disease we need to really have any sense of urgency about assessing or treating, there's not a sense of urgency that we necessarily need to keep up to speed. Because let's face it, nothing has happened for most of the 50 years since its diagnosis that has changed anything. And so there is a sense that actually it's something we don't need to, it's not as high a priority as perhaps some of the other kidney diseases that we see much more commonly in clinical practice. And so even when a patient who may have had multiple delays in getting to see us actually gets to see a nephrologist, there may be delays again in doing the test that will give us a diagnosis, which is a kidney biopsy. And I know in my practice, I deal with colleagues in other cities who see a young patient with blood and protein in the urine, perhaps half a gram of proteinuria, and they'll think this is IgA nephropathy. Why don't we put them on a RAS inhibitor, not even make a diagnosis, and just follow them up in clinic, or even discharge them to the GP, because there really isn't much we can do. And of course, these delays in diagnosis have until recently not necessarily impacted on patient care. But we are now at a stage where we have truly disease-modifying therapies that are both safe and effective. And it becomes an imperative that we identify these young patients quickly. We diagnose them, we make certain the diagnosis is IgA nephropathy, and then we give them access to disease-modifying therapies. Because actually, the risk of kidney failure in the lifetime of these patients is significant. And therefore, we must introduce a sense of urgency in how we assess these patients. And patients are picking up on this, and they're demanding now that there is much clearer and much more rapid diagnosis. They're not tolerating this delay, watch and wait, let's see what happens. And I think that's beholden on us as nephrologists to start thinking how we might want to alter our practice to facilitate that. Because, of course, we can't give all of these fantastic new disease-modifying therapies until we have a diagnosis of IgA nephropathy. And what's within our immediate control is once we have a patient referred to us is to get a diagnosis early and to treat early, because we do not want to delay these patients receiving disease-modifying therapies. Because as I'm going to show you, the lifetime risk of kidney failure is significant in the vast majority of patients. This is what I think a very important publication that came out of the UK Rare Disease Registry, looking at over 28 different rare kidney diseases. And what the overwhelming message from this was that is that collectively, rare kidney diseases have a much higher rate of kidney failure than general CKD in the population. But patients with rare kidney disease have a much higher survival than the typical CKD patient who normally or more commonly has cardiac disease, diabetes, metabolic syndrome, and is much more likely to have a cardiovascular death than ever see a dialysis machine. That is not the case for rare kidney diseases, including IgA nephropathy. And so if you go and look at the registry data, you will see that one of the most commonest causes of developing kidney failure are the glomerular diseases. And if you include in there the cystic kidney diseases, they represent a significant number of patients that are prevalent on our dialysis programs and in our transplant populations. And so we do need to start acknowledging that focusing on rare kidney disease is likely to reap great rewards in terms of reducing the end-stage population. And here's some data from the overall radar cohort. And what you will see here, there is only one glomerular disease that has a worse outcome than IgA nephropathy, and that is antiglomerular basement membrane disease. The reason for this is that patients with IgA are young. You can see by the time they present and we get our hands on them as nephrologists, they normally have established nephron loss with a GFR of usually between 40 and 50 mils per minute. And because there have not until recently been disease-modifying therapies, they just progressively and relentlessly decline to develop kidney failure. Some of those other diseases where we have traditionally thought of are much more likely to cause kidney failure actually are much easier to control because we now have effective therapies. We haven't had that with IgA nephropathy. This is a little bit more detail on a UK population in terms of what precisely we see in terms of the risks of kidney failure. And so if you look here on the left-hand side, at 20 years, half the children in this cohort had developed kidney failure 20 years after diagnosis. So that's these kids are in their 30s. And at 20 years, 3/4 of the adults that develop kidney failure. That's kidney failure in their mid-50s to 60s. And on the right-hand side, you can see by the time people are in their mid-50s, which is my age, over 3/4 of the children have developed kidney failure, and over 2/3 of those diagnosed between the ages of 18 and 40 have developed kidney failure. And that's a disaster for people who are still at a young age and still able to actively contribute to society and actively enjoy life. So this is not a benign disease, and that should flavor everything that we think about when we think about the patient pathway and how we manage this in our practice. This data really looks at what is our goal to prevent kidney failure in the lifetime of our patients. And what you can see here for an 18 to 30-year-old is if you just look at the kidney function on the day they got their diagnosis, so the time of kidney biopsy, what's the likelihood they're going to develop kidney failure based on different rates of loss of kidney function? And you can see unless we get to what is widely regarded as physiological aging of the kidneys, 1 ml per minute per year, we are not making any impact on the likelihood of these people developing kidney failure in their lifetime. And this is the challenge we face. Patients present late with established kidney disease, and they're young, which means they need their kidneys for a long period of time. Having good lines of communication that allow good relationships between primary care, secondary care, allow rapid referral and early diagnosis. So the only way we're going to deal with this in terms of identifying our patients and diagnosing our patients early. You can see here, irrespective of the age at which we present or at which patients present, we really have a tall order in terms of what we have to achieve to prevent kidney failure in the lifetime of our patients. Now, of course, the degree of proteinuria will tell us how, or give an indication of how rapid that loss of kidney function is going to be. But again, the radar data really challenges the common dogma that actually if you get below a gram of proteinuria, you're going to be fine with an IgA nephropathy. And what this data shows us is that actually 1 in 4 people with IgA nephropathy who have less than a gram of proteinuria will not be on dialysis at 10 years. So again, making us feel less comfortable that we can ignore this disease, we can take our time with this disease, we don't need to treat this disease with the respect it deserves in terms of making sure we assess, diagnose and treat early. And this isn't a peculiarity of UK patients with IgA nephropathy or the fact that UK nephrologists don't know how to treat kidney disease. This is actually something that we're seeing in cohorts from across the globe. There's data from China, from other parts of Europe, Canada, the US and India now, and other studies coming that show that outcomes in patients with IgA nephropathy are as bad or sometimes worse than I've just shown you for that UK cohort. And this is reflected in the KDIGO clinical practice guideline update, where the real focus is on introducing a sense of urgency in how we assess, diagnose and treat this disease. And you will see here that we make clear recommendation that actually we should be thinking about a kidney biopsy in anyone with greater than or equal to 0.5 gram per day of proteinuria, and that anyone with that degree of proteinuria is at risk of kidney failure in their lifetime. And so this then makes us think, how are we going to facilitate that early diagnosis? How are we going to make sure that we are picking up these people, that we are communicating effectively with people that may come into contact with these patients, so primary care colleagues, other doctors within the hospital system that we work, to make sure that we have referred these patients so we can assess them quickly. And so when we think about this conversation we have with our patients when we're giving them a diagnosis. And this was something that really surprised me, I have to say, ashamedly, is we have a patient day, and I was listening to patients talk to each other about what it was like being given their diagnosis. And normally, if you do a glomerular disease clinic, you see an IgA nephropathy patient. You might see someone with frequently relapsing nephrotic syndrome, which is really challenging to manage, and the patients are very symptomatic. You may see patients with vasculitis or lupus who have extrarenal symptoms, who are feeling sick and unwell. And the IgA nephropathy patient normally walks in looking absolutely fine. I traditionally had thought that actually, if I'm talking to someone who's got vasculitis or lupus or terrible nephrotic syndrome, that's a really serious condition. They're going to be really worried about that. But when I tell someone with IgA nephropathy they've got this kidney disease, actually, that's probably less of an issue for them. But what I was hearing time and time again is that when we tell this young person who's feeling well, who doesn't have a care in the world until they come and see me, that they have a chronic kidney disease that is incurable, they could end up on dialysis or need a kidney transplant. And I can't quite tell exactly when that might be for them. It is like a stab to the heart. These patients absolutely feel like they've been hit by a truck. And actually, that wasn't the impression that I was getting when I was talking to my patients. But actually, I have heard this time and time again from patients from across different countries, that actually the impact of being told they have a chronic kidney disease that could cause kidney failure is absolutely significant for them. So, what do we need to do to make sure that we can streamline and make sure patients get the best information that they need and the support they need? Well, we need to make sure that nephrologists understand more and more about IgA nephropathy, because there's never really been an impetus to learn or to update ourselves about this disease, because quite frankly, nothing had changed for half a century. And actually, there are lots of initiatives that we can think about to do that. And of course, we also need to acknowledge the impact of giving that diagnosis to the patient, which may not be obvious in the clinic, but actually it is something that patients are saying and telling me every time I meet them, that actually this is something that really they do need to have some support about. And so, in terms of initiatives to help educate our nephrology colleagues, there are lots of initiatives in terms of web-based programs, podcasts, tutorials. We've got initiatives by KDIGO. We've got initiatives by kidney professional organizations such as ERA, GLOMCON, really trying to get upskill the nephrologist community in terms of understanding about this disease, and understanding that actually there is a sense of urgency to make sure we get a prompt diagnosis and that we treat quickly. And of course, we're becoming far more aware of the impact on patients. And so, as a nephrologist, if you're giving a diagnosis of IgA nephropathy to a patient, we need to ensure that they have the ability to access support so that they can work through what that diagnosis means for them. And so there are organizations, and certainly when I give a diagnosis now to a patient with IgA nephropathy, I'm immediately prompting them to go to networks to offer them support. The IgA Nephropathy Foundation is a fantastic foundation that offers peer-to-peer support on a weekly basis. People can dial in, they can Teams in, and they can chat through what it's like, either being given a diagnosis or living with IgA nephropathy. We have specific things that we do here in the UK. And with all the developments that are happening in the world of IgA nephropathy, we not only need to educate our nephrology colleagues, but we also need to make sure the patients have an opportunity to learn about it. So you're going to see lots and lots of plain language summaries of the results of clinical trials that are coming thick and fast. And so knowing how to access those, and when the time is right and you have interested patients, being able to direct them to these resources is going to be incredibly important, because patients do want to know about their disease. They want to know about the exciting opportunities that may well be coming in terms of new drugs, new clinical trials. Patients do want to take control of the disease themselves, and so being able to access and offer them advice about diet, about exercise, being a healthy weight, stopping smoking, lifestyle maneuvers that are really going to be important in helping them manage from a general kidney perspective is really important because patients want to know what they can do for themselves. They need to understand they have a lifelong disease and that they are going to be coming to the hospital on a regular basis, in all likelihood for the rest of their lives. And they need to be able to understand that they are going to require treatment for this disease. And the treatment will come in various forms, and it may well be that we will use different treatments over different periods of time. Because if the patient is engaged and understands, they're much more likely to be compliant and take their medications, continue with lifestyle modification. But this doesn't happen overnight after a single consultation. And so it's really key that we invest time and effort in building that relationship with patients and communicating through our nephrology team. And it may be the nephrologist, it may be a nurse practitioner or a physician's associate, but making sure there's continued, consistent messaging to the patient about the importance of all of these factors in trying to preserve kidney function, because our goal, of course, is to prevent kidney failure in the lifetime of our patients. And that will only happen if they feel they're engaged with the kidney doctors that are looking after them. They come to their appointments, they understand what they can do themselves, and they understand the importance of the medications that they're taking, particularly when they feel well, and actually taking the medications is not going to make them feel any different. And what we're doing is giving them medications with an eye on what's potentially could happen 15 to 20 years down the line. So we have our patient that was up until that diagnosis likely feeling invincible, best years of their life, thinking about developing relationships, starting a family, developing their career, buying a house. And suddenly they become medicalized. They're given a label, they're given a diagnosis. We're going to ask them to alter how they live their life with lifestyle modification. We may well be giving them a whole series of medications that they won't have been on regular tablets before. This is a big change. And unless we get that engagement and buy-in from the patients and give them the support they need, many of them will drift away. They may not take their tablets, they may not be as careful with their blood pressure, and we run into real challenges because this is a lifelong disease and we need their engagement for the whole of their life. And so we as nephrologists need to work on how we look after these patients, how we communicate with these patients, and how we ensure our messaging is consistent. Remembering, of course, that actually many nephrologists will only have a handful of IgA nephropathy patients. And actually the bulk of the work that nephrologists will do may well be general CKD in patients with diabetes, cardiac disease, looking after dialysis patients. And it's going to be a challenge to keep up to speed with what's happening. And so it is a responsibility for the people who really focus on IgA nephropathy to make sure we can deliver information to nephrologists so they are up to speed regularly with the changes that are happening. And of course, we have our primary care doctors. It's likely that GP, the primary care doctor, may only have one patient with IgA nephropathy on their whole books. They may only ever see one patient with IgA nephropathy in their career. We can't expect them to understand the nuances of this rare kidney disease. But actually, it's really important they understand what we would like them to message to the patients. It's important that they understand the importance of blood pressure control, of lifestyle modification. It's important they understand this is a chronic kidney disease that needs to be managed by a kidney doctor. We won't expect them to know about all the new treatments, but we do want them to understand and send the same messages as we do from the nephrology side, because one of the things that patients complain about the most is when they're getting different messages from the primary care doctor, different messages from the nephrologist, different senses of urgency, and actually they don't know where to turn. And the big worry, certainly in my practice, is that they turn to Dr. Google, which is completely unfiltered. Most of it is rubbish, and actually, but it's accessible, it's easily accessible, and if it's packaged in a nice shiny website, can be believable. And this is the worry if we don't get it right in terms of talking to our patients, making sure they get the support from recognized patient support groups like the IgA Nephropathy Foundation, and making sure that the team that is looking after them is consistently messaging the same things that are important in terms of lifestyle modification, in terms of medication, in terms of follow-up blood pressure, etc. Because if we don't get that communication right, if we don't develop those relationships with our patient, the patient will go looking elsewhere. And often the data and information they get can be a complete disaster for them in terms of faddish diets, in terms of looking at novel therapies that really are untested, in terms of just thinking that actually it's all too complicated. I'm going to put my head in the sand and I'm going to stop doing everything. And it's so important in this disease because we look at patients who are young and we are going to looking after these patients for the whole of our career. And our career will not be the whole lifetime of the patient because that patient may well have 50 years of life ahead of them. But actually, our career may only be 25 or 30 years. So we need to make sure that within our systems we have clear, robust lines of communications with our patients, that patients feel involved in their care, and that they're not getting mixed messaging. Because that is something, certainly in my experience, that patients find really confusing and frustrating. Now, of course, everything I've said is not peculiar to IgA nephropathy in terms of the importance of communication between hospital teams and with the patient. But actually, it is particularly a pressing need now because we're having a flurry of brand new medications. The whole way we think about IgA nephropathy is changing in terms of a sense of urgency to make that diagnosis, in terms of how we view what is an acceptable risk profile, what our goals are for treatment, and the many, many different types of treatment that we are going to have available to us. And so here is where we do need to start thinking about how we get our information as nephrologists and how we are comfortable giving that information to patients. Because what we don't want to be in a situation is seeing a patient, them opening their phone and saying, oh, by the way, I've just seen the FDA has approved a new drug. Can I have it, please? And us not knowing anything about that drug or how we might want to use it in clinical practice, because that the patients really will not value that, and particularly if they think they know more about the disease than we do. It's a challenging time. IgA nephropathy is not the bulk of work for most nephrologists, but we are going to need to think about how we can upskill ourselves in a manageable way so that we can look after and provide the best possible care for our patients. And thank you for listening. What I've tried to do is reflect back the kind of messages I've been hearing from patients from around the world in terms of their experiences of living with IgA nephropathy and how they've interacted with the health service. And there are lots of great examples of good practice, but I think most of the time I'm hearing we could do better. And it comes down to that ability to communicate and get the patient on board with their treatment. So thank you very much for listening, and I look forward to connecting with you soon.